Good afternoon, everyone. Welcome to the Department of Internal Medicine Grand Rounds. And thanks, everybody. This is now our third session in 2022. We will remain virtual. I'm going to introduce our speaker in 1 second. Just a couple of housekeeping items. As I mentioned, we are still virtual, so the same link will continue until the further announcements in the future, possibly March or April. More communication to come on that. A couple of quick things. You can still ask questions. You can ask to be unmuted at the end, and we can promote you to a panelist so that you can join the conversation, or you can utilize the chat function or Q&A to ask questions live. Also, the attendance code will be reposted 5 to 10 minutes before the end of the lecture. Please utilize that for your CME credits. And for the house staff, the QR code will be available for attendance. And lastly, the session is being recorded. It will be up on the website shortly under Department of Internal Medicine Education Grand Rounds. So today's session is our continuation of our quarterly morbidity, mortality, and improvement. It is led by Dr. McIntosh and the quality and safety section of the Department of Internal Medicine. And I'll let her introduce the speaker, but just quickly want to remind everybody to take a look at the monthly newsletter that was sent out on Wednesday by Dr. McIntosh and leadership, provides more details and also makes references to the December newsletter that went out in terms of communication and escalation policy. So thank you all for your ongoing work in this regards and to make sure that our patients are safe. So I'm going to turn it over to Dr. McIntosh, who is the Associate Chair of Quality and Safety for the Department of Internal Medicine, to introduce our speaker, Dr. Stephen Biederman. Thank you all so much.
Thank you, Dr. Bergman, and thank you for the shout out for our newsletter. So I think this is our second Morbidity, Mortality, and Improvement Conference for this academic year. As you know, our quality directors are preoccupied with failure. In a good way. This gives us the opportunity to really work towards getting to that high reliability organization and really to improve efforts for our patients. This conference, however, is a little bit different in that the focus is a little bit more on our staff members rather than just on the patients. So that is part of what Dr. Biederman will be focusing on today, which I'm really excited about. For those that are not familiar with Dr. Biederman, he is an assistant professor in the department of, in our department in the Division of Hospital Medicine. He attended college or med school at the University of Maryland and completed his residency there and was a stellar superstar there, achieved AOA status, and that same degree of intelligence and compassion and hard work has translated to us here. Here at VCU, he serves as the Quality and Safety Director for the Division of Hospital Medicine, and his interests include interdisciplinary collaboration and connecting institutional efforts with our frontline providers. In addition to all that clinical work and QI work, he also is a monthly contributor for a medical education podcast. And on his free time, he volunteers at the Crossover Clinic. So he is a stellar example of what I hope to be. But with no further ado, I'm going to turn it over to Dr. Biederman.
Thanks, Dr. McIntosh, for that introduction. And I'm going to go ahead and share the screen. Let's see who can share. All panelists. All right, yes, I appreciate that introduction, and thank you everyone for joining for this MMI conference. And as Dr. McIntosh mentioned, the topic today is maybe something a little bit different than we typically see, but I hope to convince you by the end of this hour that the challenge of violent and aggressive patients is something that we as caregivers all need to be actively engaged in. So the goals of any MMI conference are to learn together through rational discussion about critical incidents and patients. And really, we want to talk about systems rather than individuals, with the goal overall to increase the transparency about what we're doing as an organization to try and get better. So some overall ground rules for any MMI are to avoid finger pointing and to really try and see yourself as the person who's involved in the situation, and then also to maintain confidentiality, and then think practically about how we can make things better. So with that, the objectives for today's talk are first to share, I want to share with you all why addressing patient violence and aggression is important. We'll discuss a few of the many challenges associated with defining, reporting, and then responding to workplace violence. And then finally, we'll talk about some of the ongoing quality improvement efforts to improve outcomes. Now, while I'll be the only one that you're hearing from today, the work that I'm presenting is part of a huge amount of collaboration that I'm incredibly thankful to the Violence Prevention Task Force, who I'll thank by name at the end, for ongoing work and leadership in this field. So let's jump in and start with a case. So here we had a 56-year-old man with a history of prior cerebrovascular accident with residual left-sided hemiparesis, chronic pain, chronic left lower extremity pyoderma gangrenosum, urothelial cell carcinoma, hypertension, hypothyroidism, and gout, who presents with a superimposed skin and soft tissue infection on chronic wounds. And the adverse outcome here is that the patient refuses discharge, attempts to strike staff, and requires security escort off the premise. So on day one, the patient was admitted and treated with IV antibiotics as well as IVIG. Pain control proved to be difficult to manage with escalating oral opiates on top of the patient's long-acting methadone. And on day three, the pain service was consulted. They recommended increasing opiate dosing and adding IV hydromorphone, which was added. The next day, psychiatry were consulted as the patient was presenting with tearfulness, agitation, and they actually recommended starting duloxetine, but noted that the patient was in full possession of cognitive abilities. The next day is the first indication of behavior issues, as there's ongoing issues with inadequate pain control. Pain service starts a lidocaine drip, and the patient is noted to yell at the nurse. And anytime I have something in quotes pulled directly from the record, "I give y'all an inch and you take a mile. That wound care expletive tricked me. Y'all just want me to hurt." And then the next day, this behavior escalates as the patient is observed to be throwing stool-covered wipes around the room. He then kicks the bedside table, scattering the breakfast tray contents on the floor, and refusing to get up off the bedside commode after more than an hour with staff at bedside. And quote, "The patient is frequently attempting to manipulate staff and his plan of care." So the next day, a patient care agreement is completed. And at this point, the patient has also completed a course of IV antibiotics and IVIG with plans for a steroid taper. At this point, the patient is actually medically ready for discharge to a skilled nursing facility for further wound care, but unfortunately it takes a few days for this to be put into place. And so finally on day 11, the patient is accepted to skilled nursing facility. However, when the stretcher transport arrives for the patient refused to get on the stretcher and made verbal threats to the transporters. They left and actually end up coming back twice, and he refuses both times. Then he's refusing rehab. The charge nurse gets all hands on deck, contacting the providers, the clinical administrator, social work on call, the police, security, assistant and nurse manager on call, risk management. And eventually the patient is escorted off the premises, although he continues to threaten and physically assault staff involved. And actually the police had to hold the patient's arms to prevent him from striking staff. So in summary, we had a medically complex patient who repeatedly acted out during hospitalization, used profanity, destruction of property, abuse of caregivers, and ultimately threats and attempts to strike hospital staff at the time of discharge. And I just want to pause for a moment for all of you to think, what is your initial reaction to a case like this? So, is your reaction, what's the big deal? Or is that all? I mean, admittedly, throwing stool-covered wipes around the room is absolutely disgusting, but no one was actually physically struck and the patient was successfully removed from the premises. But if you were the caregiver in the room for these behaviors, do you think this might be impacting your work experience? And one of the things that I want to drive home is that cases that don't involve a dramatic physical injury are often overlooked, even though they are a huge burden on multiple team members. And by the way, I had ample examples of cases with physical injury, but this is really where I wanted to start this conversation. So we have a case, and this is an issue that our frontline caregivers resonate with. Well, after talking to many nurses, APPs, and physicians, they would agree that this is an issue with which they resonate. I'll read a few quotes that I've heard. Abusive patients are a major reason I'm feeling burnt out. It really feels like there's an increase in abusive patients. I feel like our policy is all bark and no bite. A patient can make threats at me, but we have to wait to be hurt before anything is done. Fear of litigation seems more important than enforcement of patient behavior agreements. So I have a few quotes. I have a case, but let's take a step back and see, is this really an issue on a national level? And when we do, we note that workplace violence is an issue nationally. So in the top right-hand graph, you can see the incidence rate of non-fatal workplace violence in healthcare and how it's progressively risen over the last 10 years. And in fact, in 2019, there were over 50,000 instances of workplace injuries, illnesses, and fatalities related to violence in the hospital. And the victims tend to be nursing and tend to be female, about 70%, and also tend to be younger. And this rise has specifically been seen in healthcare. If you look at the bottom right-hand corner, you can see in the red bars indicating the healthcare industry as compared to other industries, to the point now that the US Bureau of Labor Statistics estimates that we're now 5 times as likely in healthcare to suffer a workplace violence injury than workers overall. And there's literature to suggest that exposure to workplace violence, and this is also fairly intuitive, can impair effective patient care, lead to psychological distress, job dissatisfaction, absenteeism, high turnover, and higher costs. In fact, this past year, the Joint Commission issued amended workplace violence standards, given this rising incidence within healthcare. So certainly an issue nationally. And when we look at our own data, workplace violence is an issue at VCU as well. You can see here occupational injury data over the past 10 years and the progressive rise. We won't count 2022 incomplete data set, so we can't really make any conclusions based off of that. But we can see here an increase over the past 10 years of reported physical and verbal assault claims. And it's an issue at VCU, but more specifically, workplace violence is an issue that impacts us within the Department of Internal Medicine. So here you can see the breakdown among the claims, and throughout the literature, we see that the most commonly impacted areas are emergency departments and psychiatry. But you see here that in a number of claims, the Department of Medicine is second to VTCC. And this also extends beyond into our ambulatory clinics and subspecialty care as well. So we see it's an issue, but is this something that we need to be engaged with as physicians and APPs? Well, I think to answer that, we can harken back toward the mission and vision of VCU Health, as well as the mission, vision, values of MCV physicians that have a commitment to treating team members as well as our patients with dignity, respect, and professionalism. And senior leadership is seriously engaged with this issue of violence prevention. You can see here on the left that Dr. Kellerman was tweeting through the hospital on Christmas this past year, where he sent a picture of this campaign, the Healing Not Hate campaign, for a safe, caring, and secure environment for everyone. And finally, we do have policy on violence prevention, which I'm going to read aloud because we'll come back to this a little bit later. That VCU Health is committed to providing a safe and secure workplace free from violence, intimidation, harassment, or coercion from hospital personnel, contractors, visitors, vendors, and patients. And so overall, I would also say that engaging with and committing to a safe, caring, and secure environment is really just the right thing to do as well. So to conclude, VCU is strongly engaged with this issue of workplace violence from the highest levels of organization to frontline caregivers. The workplace violence in healthcare is increasing both nationally and here at VCU. And we risk psychological distress, job dissatisfaction, absenteeism, higher turnover, and higher costs if we don't make this an issue of focus. So let's move on now and discuss some of the challenges. We're only going to discuss a few of the many challenges of this complicated issue. So to start with, what comes to mind for all of you when you think about the concept of workplace violence? Maybe you think of abusive behaviors, maybe you think of attempts to inflict harm, but I think for most of us, when we hear the term workplace and violence, and specifically the word violence, we're thinking about physical assaults, patients who are striking staff members or scratching or attempting to hurt us. And that leads us to the first challenge, knowing what is and is not workplace violence. I'm not going to read through all of these definitions from leading organizations, including OSHA, Joint Commission, CDC. But at the top here, we have our definition of workplace violence from VCU, which is adapted from the National Institute of Occupational Safety and Health. And you can see here highlighted out that there are some commonalities among these definitions. And the important thing that I want to point out here is that it's more than just a physical assault, although it includes that, also includes verbal abuse, threats, and harassment of any nature. So the elderly patient with dementia who paces through the room and strikes the care partner, causing a concussion, and all of these are recent cases, unfortunately, is workplace violence. But so is the family meeting where the family member gets in an altercation with another family member, throws a chair across the room and yells threats of returning with a gun. And so is the man with a history of von Willebrand's disease who mocks and mimics one of our attending physicians with racist and sexist remarks, bringing the physician to tears. And I think that we really need to start here as the most important issue, because if we don't recognize that the definition of workplace violence is more encompassing than simply physical assaults, we risk the second challenge, which is that if we aren't clear on the definition, we risk normalization of workplace violence. And this is seen time and again in the literature and really in shared experience just in talking with staff who commonly view workplace aggression as an unavoidable part of their job. Staff also commonly believe that reporting an incident will not result in any change and lack understanding about which incidents merit reporting, leading to estimated vast underreporting of workplace violence. And I want to read this quote, which I think is, which I found pretty compelling. So many factors contribute to the occupational risks facing nurses today, but a fundamental problem is a healthcare culture that focuses more on patient safety than on worker safety. Healthcare is not considered a particularly dangerous profession, yet when violence does occur, it is often labeled as part of the job. I would argue that this is unacceptable for nurses, but for all of us to normalize workplace violence. So we're taking it serious. We want to report it. Our third challenge is, where do we report a violent or aggressive patient? So should we be reporting using VCU Health Safe, our new reporting platform for safety reports? Or should we use the reported occupational injury app, which is available on the intranet? So many of you may not even be familiar with the app that I'm referencing down here. But really, this is the source that VCU Health uses to track and monitor how we're doing when it comes to violent and aggressive patients. So that bar chart that I shared with you earlier, showing the progressive rising for the past 10 years, is based on data through the occupational injury app available on the intranet. And I think that this is a challenge for many many team members who may not be aware that this is really where we need to be reporting either a physical injury or a verbal assault. And according to our policy, our procedure, for cases where assistance or process opportunity led to an assault, we should be entering a safety report. So could be perceived as a bit confusing. And finally, the fourth challenge I want to mention, and really this is the most important one, is that when it comes to the actual in-the-moment support and response, we get diverse disciplines involved with varied roles. So I'm going to just walk through a hypothetical situation, which I'm sure many of us can resonate with, but I've seen something similar many times. So we have a patient who starts escalating and acting up, maybe is attempting to strike or harm a bedside nurse or care partner, and they put up with this behavior probably for far too long, and finally they're scared, they're worried, they're at their wit's end, so they reach out to the attending or the APP or the resident intern and say, you got to help me, this patient's going crazy right now, I'm scared, you need to restrain them. And then the APP and attending say, well, what do you want me to do? Do you want me to come hold them down myself? I can't do that. we get the charge nurse involved, and then we end up involving, maybe we get psychiatry to come urgently to the bedside, or the RRT team. We end up involving security and the police and risk clinical administrator. Before you know it, we have over a dozen different people weighing in on this patient's care in the midst of a very stressful situation. And the question that comes up again and again is, when should these parties be involved and how should they be involved? So I want to just take a moment to talk about some of the existing resources that we have for violence prevention here at VCU, because we actually have a lot. And I can't get into everything, but we'll talk about three major things. First is our policy and procedure for workplace violence. And then I want to talk about two of our major tools for combating violent patient behavior. Those are violence flags and patient care agreements. So to start with, we have the VCU's policy and procedure for violence prevention. So this is a riveting 8-page document, actually not that long, but has a lot of detailed information highlighting our organizational approach to violence prevention. I read the policy before, so the document really talks about the procedure, breaking down the process to preventing a violent act, to immediate event response, and then our post-event actions and recovery. And while there's a lot of information in there and resources, the major tools that we see used often are patient care agreements and then the risk for violence flags. So first, to talk briefly about patient care agreements. So these are documents that set expectations and goals for family members or patients who have demonstrated non-compliance to the treatment plan or for inappropriate behavior. And so basically, a patient care agreement is us laying down the law, saying you need to comply with this plan of care, you need to stop yelling at the nurse, using profanity, and here are the consequences if you don't. And the consequences can include up to restriction of visitation and or discharge from the hospital. And a recent change is that while it's highly recommended to use the expertise of risk management when you write this patient care agreement, it is not required. I have a graphic here that shows the specifics of patient family care agreement here. And so pretty simple in its structure. To start with is what we need from the patient, the consequences of violation, and notably that this patient care agreement is enacted regardless of it being signed. You can see here that when we enact this, they're written essentially from scratch every time because every clinical situation is different. And it can also be tricky because there are some things that we can do, some things that we can't do, which is why it's recommended to talk to risk management in crafting these documents. For example, we can't take away a patient's personal property, their cell phone, or any personal devices. And there are situations where we can't discharge a patient for not complying. So we sometimes need to get creative in how we're talking about consequences for patient care agreements. I want to introduce this because we'll talk more about this when it comes to the improvement phase. And the second piece are violence flags. So we have 3 levels of violence flags, which will now with EPIC appear on the storyboard, as you can see here in the graphic below. Level 1 is verbal violence. Level 2 is physical violence without injury. And then level 3 would be physical violence with injury. And a change recently in EPIC is that these are entered at the person level. So previously with Cerner, if I entered a violence flag, that would stay with the patient until that encounter was completed. So when they were discharged from the hospital, that violence flag would drop off unless it was entered by risk or security. That means that the next admission, we wouldn't see that violence flag any longer, or it wouldn't carry on to an outpatient appointment. So that's a change in EPIC, is that these will stay with the patient until until they're reviewed and removed, until they're reviewed and actively removed. So to conclude, this section, workplace violence is difficult sometimes to define and identify, but it includes both physical and verbal harassment. And physical or verbal harassment of any kind can't be normalized or should not be normalized as just part of the job. Reporting aggressive patient behavior isn't necessarily intuitive, therefore it may inconsistently occur. And then when it comes to responding to a violent patient, we have an array of disciplines and teams involved, and not always with clear roles and responsibilities. And finally, VCU's major resources for prevention of violence center on education, use of patient care agreements, violence flags, and then a multidisciplinary response to aggressive patients. So with that, let's move on to our third objective, which are to describe some of the ongoing QI efforts to improve our outcomes. So to frame this conversation, I'm going to use a quality improvement methodology called Lean Six Sigma. And this is a quality improvement methodology that was piloted or initiated in the auto industry, and it uses data to guide improvement efforts, specifically focusing on looking at processes and removing redundancy and eliminating wastes. But I think it's helpful for us to think through kind of a structured format when we address this complicated problem. And so the thought process for Lean Six Sigma, or one of the methods is using the DMAIC framework, where you define a problem, you measure the problem, analyze, improve, and then enter control phase. So we understand, or hope you agree, that we've got a problem, but we need more information about what's going on. So let's dive into a little bit more details of the specifics. So we've taken a few different approaches to understanding this problem of patient violence and aggression. And the three I'm going to talk about here are a needs assessment we conducted among hospital medicine physicians, APPs, the departmental house staff, and some of our nursing partners on North 5 and North 6 to gather insights about perceptions related to violence prevention. The second method was a stakeholder roundtable, where we had interdisciplinary discussions with many of the parties involved in these critical scenarios: physicians, APPs, performance improvement, nursing, risk and administration, where we really try to go deep and understand some of the anecdotal pain points and nuances of patient violence. And then third is density analysis, which is simply just chart reviews looking for commonalities and trends within the record about patients exhibiting violent behavior. And just a word more on the survey that was sent out. It was a brief 9-question survey, contained one optional open-ended question. It was distributed, like I said, through hospital medicine and then to our Department of Internal Medicine house staff. And we really had good response rate with over 112 people completing the surveys, and more than half of them completing the open-ended response, and a good array of house staff attending and nursing involvement. And although we see that by percent our APPs are a little bit lower, this is a smaller population, so we actually had the highest proportion of APPs completing. So props to them. All right, so what did we learn? So our first insight is that about 50% of respondents indicated that they have been a victim of a violent or abusive patient in the past 6 months. See here on the left, we asked if over the last 6 months if they had been a victim, and 47% of our respondents said yes. Very high numbers. And on top of that, almost 50% of respondents did not agree with the statement, "I feel generally safe from physical or verbal harassment at VCU." And by the way, these questions were specifically asked in reference to patients. On top of that, more than a quarter disagreed with the statement of feeling generally safe from physical or verbal harassment at VCU. The second insight was that confidence in our existing tools for violence prevention and real-time incident resolution is lacking. On the left here, we asked how folks agreed with the statement that VCU has systems in place to effectively ensure staff safety. And about 55% of respondents agreed that we have the systems in place. But only 25% of respondents agreed or strongly, or only 25% of respondents indicated confidence in issue resolution following reporting. So after they report an incident, we don't have a lot of confidence that the issue is going to be resolved. Insight 3 came from our stakeholder roundtable and chart review, is that our violent and aggressive patients can very generally be categorized into 3 different groups. So first, we have delirious or demented patients. We have patients who have a primary underlying psychiatric condition, and then we have violent patients that's non-clinically induced. And in in-depth conversation, we recognize that our response needs to be tailored to the different types of patients. So for example, a patient care agreement is not going to be helpful for a delirious or demented or psychotic patient. And so we're going to have to tailor our approaches to these different groups. And finally, insight 4 is that it's difficult to understand the course of events simply by looking back through the medical record. And I've seen this time and again, debriefing with staff members after incidents, is that the documentation surrounding such events is limited. So when I talk to a physician about a difficult patient scenario, I get a whole story, a lot of detailed inappropriate behavior, but sometimes when we look back in the record, we see very sparse documentation. And inconsistently do we reference in any specifics of patient behavior, documentation of security or BERT, behavior emergency rapid response comes to bedside, or behavioral contracts. And this is crucial because really the medical record is what we're looking back through to try and understand some of these cases and what's going on. So using some of those insights and more that we've gathered as a team, I've got a few problem statements here to define the problem. So first, workplace aggression from patients is increasing in prevalence, is underreported, and frontline staff indicate a gap between the effectiveness of institutional tools and interventions and their own experiences. Second is patient care agreements are not perceived as effective, and the process of enacting one is viewed as cumbersome. And third, violent and aggressive patients follow multiple distinct patterns for which strategic approach must differ. So how do we measure this problem? Well, currently we have different possible ways to attempt to measure both the incidence and the outcomes from violent patients. So I told you earlier that the occupational injury reporting app available on the internet is how we as an institution are measuring the rates of violence, both verbal and physical violence. We also have the ability to enter safety reports for aggressive patients. But looking forward, maybe we have opportunity to track outcomes from our patient care agreements themselves. So when these patient care agreements are enacted with a patient, is it effective? Is it resulting in, or is it, I guess, stemming any further violent or abusive behavior? And are we tracking our violence flags? I think overall, when it comes to measuring this problem, we need widespread knowledge of the consensus means by which we're tracking incidents of violence and violent patients, so that everyone is on the same page, of when we're measuring this problem, how we report it, and how that's going to translate to the overall big picture. So in analyzing the problem, what do we do now? So, I've shared with you that folks on the front line are indicating that they've been a victim of violent or abusive patients, and that there is some opportunity for improvement in our confidence in the tools to respond to these types of patients. But it's also difficult looking back to see where those opportunities might lie. So what do we do? Well, action plans, I think, are going to have to target multiple steps in this process, as we already see that there are issues kind of across the continuum. And though leading organizations like JCAHO and OSHA do provide guidance frameworks, data on specific interventions is lacking. In fact, in a 2020 Cochrane review, a grand total of 7 randomized controlled trials were found on interventions specific to prevent and minimize verbal or physical aggression. And actually, none of these were on inpatient medicine floors. They were all in the emergency department, psychiatry, and nursing homes. And these interventions were, on top of that, were maybe, I would say, not necessarily what we would be reaching to for first line. So for example, one of them at nursing home was an intervention of playing calming music to try and limit workplace violence. And there may be a role for that at some point, but I don't know that we can make our solution when a nurse is calling for help, just turn on some Adele and that'll work just like a charm. Overall, there's lack of wide consensus there is a wide consensus that there's no single intervention to improve outcomes. But generally, interventions have targeted 3 categories: education and training, the actual physical environment, and then organizational policies, procedures, and interventions. So despite the noted limitations in measuring the problem that I talked about just a moment ago, I do think we have ample grounds for entering into the improvement phase. You'll see here what's hopefully a familiar graphic to all of you, which is the hierarchy of intervention effectiveness. And basically, this helps us categorize and group different types of interventions when we're looking at quality improvement. So on the bottom, you see here people-focused interventions, and these are critical, especially early in quality improvement, and are critical for change adoption. But in the long term, we often want to look at systems-focused interventions, which can be more sustainable. And I believe that at this point, we have the right inputs to make significant gains when it comes to the issue of workplace violence. We've got the right stakeholders around the table with the Violence Prevention Task Force. We have the expressed leadership support to engage with this issue, and we've already learned a lot about the pain points. So what will our interventions look like over the coming months? So as I said before, we need a multi-targeted approach across disciplines. And here are some of the ways we anticipate impacting this issue. So to start with, we can have real-time reminders of potentially violent patients with violence flags that are visible both on the storyboard within Epic, but also with physical markers outside of rooms. A change that was added a little over a year ago, but needs full adoption across the organization. And then we need consistent messaging and shared understanding, particularly for our new nurses and our trainees, that staff safety absolutely must come first. And this is even at the expense of a patient falling or pulling out an IV. We have to keep ourselves safe in order to be able to care for others. We also can establish some general algorithms for those different categories of patients, the delirious and demented patients, psychiatric, and then non-clinically induced aggressive patients. So we ensure that we have the right people present at the right time. And what that means is that we're going to need ongoing collaboration with psychiatry and our BERT teams. And I'm thankful that they're actively engaged and committed to this issue as well. But overall, we want to be able to delineate the different roles and responsibilities when it comes to these aggressive patients, so we can empower our nurse colleagues and our care partner colleagues to effectively escalate. And we can also assist the resident or APP in having a clear sense of what their role must be or role should be in the process. And I think all of this starts with increasing our health system-wide awareness and understanding of this issue. Using our existing channels of communications through QAPIs and our nursing shared governance to educate on the what and the where of violence and aggression, and specifically drilling down with our physicians and APPs on the specifics of patient care agreements, something that we're doing next week on hospital medicine. And then thinking bigger to our systems-focused interventions as we hopefully exit the stabilization phase with Epic. I think we have a tremendous opportunity to leverage the EHR. So for example, we can add an Epic alert that a patient care agreement has been previously put into place with a link to that file. And this could be huge, so we don't feel like we're reinventing the wheel when it comes to a violent patient coming in, and we can see what worked or didn't work the last time a patient was here and was exhibiting this type of behavior. And then another word about patient care agreements, we need to make the process more seamless, and this is something that risk management is actively engaged with assisting us with. Because if this is one of our major tools with which to combat patient violence, we have to make them easily accessible and deployable. And along the way, we also need to continuously gather more and more data. I really think we need to quantify our outcomes after patient care agreements are enacted. I've said before, but these are overall quite unpopular to enact, to put into place, and viewed as ineffective. So if the tool isn't working, then maybe we need a new tool. But if the tool's working and we're not putting it into place, then we've got to make it easier for our frontline staff to be able to use that tool. But I can't tell you that right now. So I think that moving forward, we need to look at the outcomes after we use this tool. We're also talking on North 6 about having in-the-moment formal multidisciplinary debriefs for some of these cases of patient aggression on the medicine floors. And that will allow us to provide real-time, so that will allow us to get real-time insight into the process, what works, what doesn't work, and how we can make the process better. It'll also allow us to provide feedback to frontline providers, both about their documentation, and their role in the response to a violent or aggressive patient. So I just want to say for a moment that, I'm presenting work that we anticipate is going to be transformational, but this is a part of the process that's been going on for years through the Violence Prevention Task Force. We've been deeply committed to making meaningful change in our organization and have a huge list of accomplishments over the past 5 years. So we're part of a journey. We recognize there's more work to be done, but I think we also need to take a moment to celebrate the tremendous progress that has been already done to make our environment more safe. So to conclude, patient violence is a complex issue, and it really does impact all of us. And organizationally, we have made substantial progress in our response to violent and aggressive patients, but recognize there is much more to be done. Multidisciplinary collaboration, both in our strategic approach overall and in the moment, is vital to achieve meaningful impact. And the Violence Prevention Task Force is fiercely dedicated in efforts to ensure a safe, respectful care environment for all. As with all quality improvement, this is a team effort, and trust, respect, and humility are absolutely essential. So with that, I want to thank a few people specifically. Veronica Nolden, Taylor Green, leaders of the Violence Prevention Task Force, Margaret Konechny from Risk Management, some of our nursing leaders very strongly engaged with this, Jen, Allison, Martha, Amanda, some of the hospital medicine team, Stephanie and Alex Rittenberg, and then Nancy O'Reilly, as well as the rest of the Violence Prevention Task Force, which is a very large group, couldn't list everyone by name, for their ongoing active work with this. Also want to thank the quality and safety leadership in the department, Dr. McIntosh, Haim, Mary Helen, Kristen, Carol, Rabia, and then Dr. Fieser for her support. And then finally, Dr. Dow and Dr. Syme for their ongoing support for our quality improvement efforts within the division and the department. So with that, I will be happy to take any questions.
Thank you so much. Dr. McIntosh, do you comments, thoughts, reflections?
I think that it's such an important topic, and I really appreciate thinking about this from such a comprehensive and really data-driven approach, rather than it being a focus of an emotional response. So really, thank you for that. I've learned a lot in this just short time in talking about this and thinking about my own experiences and experiences that our frontline staff have experienced themselves. I wanted to make sure that you saw some of the comments from Lisa Davis, who helps to direct the BERT team, making sure that we know that if a patient if discharge is an option, that is one of the options that you can put into that patient care agreement. I think there was a comment from one of our providers in that it felt like it was not part of that option, but if the patient does have capacity, I think that is absolutely one of those options that you can use.
Yeah, so looks like Lisa Davis raised her hand, so if I don't know how to do anything about that.
Yep, Lisa, you should be able to chime in now.
Yeah, can you guys hear me?
Yep.
Yes.
All right, sometimes my computer audio is crap. Sorry. Just now, what we do see sometimes with patient care agreements is that the consequence will be listed as discharge. And that's really not a clinical option, but it's written on the care agreement anyway. So it gets really, really frustrating for all involved if we can't carry out our part of that patient care agreement. And I think that's part of the feeling why folks feel like they're not effective. So just like we are as parents, when we set a consequence associated with a behavior for a child, it's got to be something you're willing to carry out. My husband early on would say, you're going to be grounded for a year. And I would look at him and go, okay, if we ground the 5-year-old for a year, that means we're grounded for a year. Like, you know, you're not going to do that. So though the idea of discharge sounds magical for some of these cases, please don't put it down there if that's truly not a clinical option. And always remember, we have the option of leaving the room when a patient is verbally nasty. Sometimes we forget that. Unless the patient can chase us down the hall, one of our best interventions is to say, right now, you're really angry. I get it, but I'm going to leave and give you some time to calm down so we can have a productive conversation. And then you leave. Like I say, unless they can chase you. And then make sure you run faster.
Thanks for chiming in, Lisa. And I think that's a good point. And I think this is, you know, I guess anecdotally where some of the frustration with the patient care agreements might lie, in that we are sometimes limited in the consequences that we can offer. And, you know, in talking to risk management specifically about these, one thing that they are that they hope to do is to help us out by giving us some commonly used consequences that we can maybe more easily enforce. Because the reality is we also, you know, our patients have rights as well, and we need to make sure that I guess we're doing our best by them as well. And I think that what Lisa said in that threatening things that we cannot do is kind of undermining our whole system. And I will also say that risk management's position, although this may not always be experienced, is that they will support us in administrative discharge. But one of the challenges that I mentioned is the documentation surrounding, and I can definitely attest to this in looking through, is that for many of these cases, what like I'll talk to the team about what they're experiencing, and it's absolutely horrible. And then when I look in the record, it's something like patients exhibiting questionable behavior, or like very non-specific and nothing that we would really be able to defend if there was an adverse outcome as a result down the road. And so I think there's opportunities on every level, both in understanding what we can and what we can't so-called threaten our patients when they are acting out, and then how we can help ourselves in that process. There's another question about, is there been work done on no admit policies? And to me, or to my knowledge, there is, I don't know of any work on a no admit policy. I know on the outpatient side, there is work done by risk management on the concept of so-called firing a patient, or the documentation surrounding the documentation you would need if there is no longer a therapeutic relationship between a physician and a patient. I don't know of that occurring on the inpatient side. Brian Castle asking, is there any mechanism for alerting the home-based services that we are involved in about patients' history of abusive or violent behavior? Well, I think, so with EPIC now, violence flags will carry with folks across all encounters. So they'll carry outside of the admission. If folks don't have access to EPIC, then I think they're relying on, I guess, our documentation through a discharge summary. And I think this also goes to show how important the documentation is.
I have a quick piggyback question on that. Work in the geriatric division, so we do see a fair number of nursing home residents, and lots of people are being tagged with these person-centered tags now, violent flags. Question about what the follow-up plan is. So if somebody has a one-time episode of care in our hospital system and gets a violence tag, and they are not normally associated with VCU, on the provider level, we cannot remove the violence tag. So when I see the patient in the nursing home or long-term care, I can't remove it from EPIC. And I was wondering if you could touch on you mentioned that there's a review process in place for those patients who have violent tags placed. You said there was a review process. Is that quarterly, yearly? Wondered if you could touch on that maybe.
Yeah, I think it's a good point. So we see this as well. So like a level 3, the highest level violence flag placed on someone maybe who was delirious after a surgical procedure and really probably is not going to be necessary down the road. I don't know that we actually have, so this is a change, right? That we have the violence level flags being always going with the patient and not the encounter. That's a change with EPIC versus Cerner, where it would be encounter specific. So I actually think that we are probably going to need to establish that review to look and see when it's appropriate to remove those, because it is a change with our new system.
And just another piggyback, Alan asked just a second ago, what would be the role of the leaders? Just 2 quick caveats that come to mind. I was wondering your thoughts on the HELP program, Hospital Elder Life Program for delirium, that's been in place for a while now, focused on early recognition of risk factors through the use of an EMR. And there might be an opportunity to do something similar across patients who have exhibited a pattern at the time of admission. So I was wondering about identification of risk factors upon admission. So that's one question. The second question was at the time of the behavior, assessing capacity and documenting in a standard fashion what the behavior was done. We often see that on the consult service in geriatric medicine. It's hard to identify exactly what the behavior was. And I was just wondering, on the provider side, APPs and docs, it may be with EPIC, is there an opportunity to have a smart phrase, kind of a standard assessment template? Thanks.
So I guess the first part are risk factors for violent behavior, and these have been characterized, on the outpatient, things that have been associated with violent behavior are long wait times, increased staff turnover in crowded areas. And then other risk factors associated are really some of the categories that we broke into our patients down kind of into. Patients with dementia, patients with delirium, and then patients who are substance abusers or have a primary psychiatric condition. I mean, those are some of our biggest risk factors, as well as individuals who have demonstrated violence or aggression in the past. So I think that right off the bat, that's unfortunately a huge population of patients, probably both on the in and the outpatient side, that are going to be at risk for, or that could be at risk for violent and aggression. It's also part of why we're attempting this density analysis to look and see at VCU what are some of the issues, because there are things that we are trying to think outside the box. So maybe, and I'll also say, this has been compounded with COVID, because some of the things that we combat dementia or delirium with is having frequent reorientation from a family member that can provide that reassurance and maybe mitigate a violent episode. And we're losing that, right, because of our visitor policy. So I think, I think we know many of the risks, and we've done work already through the delirium task force and improving our recognition, for example, of those who are CAM ICU positive. But I think early recognition, I guess your point, is going to be key. And I think part of it is that we need to improve our in the moment response, but really prevention would be even better. And then your second question was about, I guess,
around like standardization of the assessment at the time of the, when you were called about the assessment as a provider, what was the initial intervention? And I think a lot of that currently is falling on the nursing staff to document that, and potentially a birth alert and consultants. But as primary teams often being called about it, there might be an opportunity to have a smart phrase, so to speak, in EPIC that standardizes, some of the chart language or things that are present in the language in the chart.
Yeah, I think that's an opportunity for yeah, potentially looking forward. I know that I'm all for smart phrases and making a process simpler to document. And I know that in our chart review, you know, a lot of times we're looking for buzzwords in the record that just are inconsistently there. And so anything that we can do to make it easier to express exactly what's going on is a good idea, and things that we need to be putting on the table. And I would say also options that we maybe didn't have available with Cerner that we now have in Epic. And I do think it's a great idea and something that we can look at as a violence prevention task force. Yeah, and Margaret agrees. And Lisa says Dr. Bowie is an expert on delirium and she's happy to be consulted. And she's also a member of the Violence Prevention Task Force and is really strongly engaged in this work as well. And I think the partnership with Psychiatry is really going to be super important for us moving forward.
Just a quick comment, Dr. Dow's comment about leadership. I don't know if either you or Dr. McIntosh wanted to take a stab or answer that.
Well, I think these issues, when they arise, I guess to so, you know, I would say our goal would be to be able to, as a health system, have effective tools that these situations can be mitigated without, you know, escalation to the realms of leadership, but also recognize that current state, we have gaps and we have opportunities to improve. And I think that, and what I've heard from leadership is that they're engaged with this and they want to know when these breakdowns are happening, when we're having an inappropriate response from our nursing leaders, or having an inappropriate response from our physician, or risk, or there's tension, or there's hostility, or, you know, whatever the breakdown in the system is, or, you know, we've done everything we could and the patient is still, you know, not allowing for any other patient care to happen. I think in those kinds of situations, we got a lot of smart people in the institution, and sometimes putting our heads together and collaborating, kind of having a huddle is a way to get to a solution. And I guess having leadership support in that is one way that they can help.
Thank you. Can you go back to the slide that has the Violence Prevention Task Force and its accomplishments in the last 5 years? I don't know if everybody was aware of all of that wonderful work. Yeah, thanks. If you could leave this up on the screen for people to see, I think it would be helpful. Any other comments, Dr. McIntosh? Sorry.
The only thing I was going to say is I think one of the most important things from leadership is clear and consistent and unwavering approach when we have issues with patients, really, no matter what level, what degree, that if this is a safety issue from clinicians, from staff members, that the same approach really should be taken within those 3 categories as you laid out, but not having different rules for different patients, I think, is one of the things that I see that leadership can help support our team members with.
Thank you so much for a wonderful presentation today. Thank you, Dr. Biederman. We really appreciate that and ongoing strong work and support for staff and patients. So thank you. That's the end of our Department of Internal Medicine grand rounds today. We're going to put back up the QR code for people to record their attendance, and the CME code will be posted in the chat. As a reminder that this talk is recorded and will be available online if anybody needs anything. Thank you to Dr. McIntosh and Dr. Biederman today and the Department of Internal Medicine leadership. We appreciate ongoing support. You all have a good day. Thanks.